webinar. My name is Meg Beyer. I am part of the Managed Care Technical Assistance Center team, and I will be the host of this morning's webinar along with some of our partners from OMH and OASAS. Before we get started, I do have a couple logistics to run through, just in case you are wondering. We are recording this webinar, and both the recording and the slides will be available following the webinar today. So for those of you who are on the line, if you want to refer back to the information that you hear or share this information with colleagues, fear not. This information is going to be made available to you all. It does take our system a day or so to download the recording, so you will receive it in a couple days, but just know that this will be available to you along with the slides following today's webinar. The other thing I want to reiterate is that as we do on these webinars, we save time at the end for Q&A. So while we are saving time at the end of the presentation to respond to the questions, we want to encourage everyone to chat in their questions throughout the entirety of the webinar. We, again, allocated time to respond to your questions, but that doesn't mean you have to save your questions until the end. We encourage you to chat them in throughout the entirety of the webinar. And what I want to ask, because we have a number of really wonderful state colleagues who are on the call with us today, if when you chat in your question, we're asking that you select the all panelists option to chat in your question. So if you're looking at the right-hand side of your WebEx screen, you'll see under the chat box functionality, if you click on the little button that says chat and there's a little chat bubble, click on that and it'll bring up the chat box. When you chat in your questions, what we're asking you to do, you'll see a line that says send to. And if you click the arrow that's pointing down to the right, if you could select all panelists, that means all of our state partners will be able to see the questions as they come in. MCTAC is going to collect all the questions, so those that we just don't have time to answer today or that the state isn't able to answer today, fear not, the state will receive all the questions and they can review them and respond to them in the time that they need. So please don't hesitate to chat in your questions. We are collecting all of them. We'll see them all. Whether or not we can address them all today is another thing, but just know that the state will be receiving all of your questions. So on that note, I want to thank everyone again for joining us today. And with that, I'm going to ask our partner from OMH, Laura Salco, to start us off. Laura?
Thanks, Meg. Good morning, everyone. This is Laura Salco with the Office of Mental Health Division of Managed Care. We want to thank all the MAP plans for attending today's session. The purpose of today's webinar will be to provide an overview of the adult mental health outpatient programs as well as the OASAS programs. We thought this would be really valuable information for the MAP plans, especially those that have never covered these services before, in preparation for the January 2022 implementation. And after the program overview, we will go into, as Meg had said, a question and answer session. And we did provide at the end of this presentation responses to questions we had received from the previous webinar in April that you can refer to when these slides are sent around, and the MCTAC will facilitate the live Q&A session. And then with that being said, I will hand it over to Nicole Haggerty at OMH to start the presentation on the MH services. Thanks.
Thank you, Laura. We can go to the next slide. After that, too. Okay, thank you. So hi, everyone. My name is Nicole Haggerty. I'm from OMH, and I'm going to go over the adult outpatient mental health programs, both those that we have today and some that we are working on or are in development. You can go to the next one, please. Okay, and so before we dive into the services and program types themselves, I just wanted to start with sort of this important underpinning that is applicable across programs and services in the community mental health system, and that's the concept of recovery. And I won't quote Bill Anthony and read the entire thing, but I think what's important to understand is that throughout the system, the way that decisions are made about program and service delivery are so that we can work towards a, what people often say, person-centered, recovery-oriented work driven by the individual, and that really kind of acknowledges that individuals' health is affected by multiple domains in their lives, and wellness and helping those individuals live a self-directed life to meet their full potential requires multiple different services, an array and a choice of service types, and of course, self-directed treatment and recovery planning. Go to the next one. So these are some of our big state planned services in terms of how many people access them. I think probably most people are familiar with outpatient clinic, and I'll talk about that a little bit more. I probably less so, folks that may be familiar with personalized recovery oriented services, which is our PROS program, and that incorporates rehabilitation along with treatment in a very intentionally recovery oriented program with multidisciplinary staff. And I will get in more detail into that as well, but I'll refer to it as PROS moving forward. And then, oh, sorry, go ahead. Okay, thought I heard somebody. And then assertive community treatment, which most folks are familiar with, as it's an international evidence-based model. And New York, of course, has our own adaptation of that, including an interdisciplinary team with treatment and rehab services also provided, largely community-based mobile program. Okay. So the Article 31 outpatient mental health clinics, that is our largest program in the way of number of individuals served and the number of programs we have. So while we actually have 487 licensed clinics statewide, we have many more satellites, school-based satellites or satellites run by clinics who also serve adults in different areas, and that's in that community as so, important to note that this is a far-reaching program and also serves a lot of different populations, individuals who may be presenting with, interpersonal challenges, marital conflict, for example, to somebody who has, schizophrenia and challenges with substance use. So a very wide-ranging program. About 85% of that program has individuals who are using Medicaid for service. And a component of our current Article 31 programs is intensive outpatient program, which, in short, just means that people are able to access the clinics more intensively for shorter durations as needed, including individual and group therapy with increased intensity. What we wanted to just get folks thinking about today and understanding is that we are in a very active process of thinking about clinic for the future for many reasons. And the state's actually in the middle of going through a CMS process where we're moving our clinic service to what's called the rehab state plan amendment. And that would allow us to have a little bit more flexibility and help meet our goals around access and engagement. The clinics in the rehab option, different from the clinic option today, largely will have the ability to go off-site. So clinicians can go into the home and community to provide those same clinic services, where there are pretty significant limitations in how they can do that now. We are also looking to add peer support services to the Article 31 clinic license with this pending CMS approval. And we also believe that move will support facilitating integrated care because, as you may hear later on, OASAS also has their clinics in the rehab option. So we are really trying to get our regulations aligned to the extent possible for that fluid process for the enrollee or the person receiving the services. We also are really trying to have a focus effort on looking at where our regulatory structure may contribute to administrative or documentation burden that is not helpful to the providers, because we know that's been a growing pain point. So most recently, we, for example, instead of having treatment plans due every 90 days, we increased that from an OMH regulatory standpoint to annually or as needed. And that way, as treatment plans are needed to be changed, the clinician would drive that practice rather than, state regulations. Also, what's emerging for us about the population served, as I said, it is a broad population served, is that we're looking for better ways to address social determinant needs of the population. So folks really come in unemployed, they may be experiencing loss of housing, be isolated from friends, families, or natural supports. So looking for ways that we might be able to use things like alternative reimbursement models to support individuals who have goals and needs beyond just, treatment in the way of psychotherapy and medication management. So I think I'll stop there. You can keep going. There's also effort for integrated outpatient services licensure, which is a process where the state is working together to look at how to really achieve clinical integration. And there are already about 144 approved sites out there. 99 are OMH hosted, 83 SUD, and 11 with primary care. 5 of those sites include all 3: physical health, substance use, and mental health. And there are also projects from District 3AI where there is revenue for clinics from what that is previous dollars, where these sites also offer integrated and more innovative practices in the way of integrated services with primary care and SUD. Okay. So shifting from clinic, which again is probably most well known, within our programs, we have psych rehab, and that is a very important element of some of our programs, as this really, we have found, has helped individuals to launch beyond just symptom stabilization and to really start to gain meaningful roles in their community. And psych rehab is an approach that helps people acquire the skills and supports they may need to move forward in their life role goals. As I mentioned before, social determinants of health, things like lack of housing and employment or education, really can hinder people's progress in their recovery. Some people say employment is recovery when it comes to mental health. And so those sort of meaningful, purposeful goals can actually accelerate someone's progress. And so we make sure that we have these skill building opportunities within our programs and that individuals have access to them to move recovery forward. Okay. Thank you. So ACT is one of those programs that includes treatment and rehab, and actually care coordination as well. And so again, I'm going to assume most people are relatively familiar, but the thing that makes ACT the most unique is that it's community-based. So this is a team of individuals, including a nurse, psychiatrist, social workers, peer supports, family support specialists, employment support specialists, substance use specialists, and they go out in the community. We have a fixed program in New York State of either 48 or 68 individuals served at any given time based on the team. And these, the individuals who access assertive community treatment, you do have to go through a SPOA, the local county single point of access, in order to gain a slot in access to that program. So these are individuals who are prioritized based on their significant need for services like multiple hospitalizations or ER visits, criminal justice involvement, and overall lack of engagement in traditional services. So these are individuals who may have tried to attend a clinic outpatient treatment and was was unable to, consistently attend, and which had resulted in things like multiple hospitalizations. There's a low individual to staff ratio, which is consistent with the national evidence-based model. It's 10 to 1. And I mentioned those that diverse staffing of clinicians and paraprofessionals as well. Okay. We have 108 ACT teams in New York State. We've significantly increased the amount of teams that we had even over the past 5 years. In the city, we have shelter focused teams that work directly and are connected with mental health shelters in New York City. And we also have about 7 forensic ACT teams. They're all licensed as ACT, but they focus on these special populations, and the ACT team, beyond just bringing in the clinical expertise, also brings in the population expertise and focus. And we do a lot of monitoring for outcomes, and we know across the state, you can actually find this information on our public website, that our ACT teams are in fact significantly decreasing hospital admissions and ER visits for individuals on the ACT teams. They're housing people who have been homeless for years, and they are very effective in the way of, addressing substance use, self-harm, forensic challenges. They also serve individuals on AOT or court-ordered treatment. And so we have a very good partnership with Center for Practice Innovations, where we, to keep with the fidelity of the model, provide a lot of support and training for our ACT team so that we can evolve as the population served evolves as well. Okay. Okay, and for pros, this program includes rehabilitation and treatment. That means there's a psychiatrist as well as rehab practitioners. We have these programs across the state. They are primarily site-based, although right now, due to the pandemic, they are doing a little bit of hybrid models of both telehealth and on-site. Prior to COVID, these were on-site programs, primarily group-based. It moved us out of continuing day treatment, where people would just come for therapy and kind of sit in psychotherapy groups. And instead, the focus is about goal directed work. So some people have a goal to go back to work, or through an education program, or they may have a socialization goal to reconnect with family. And in pros, it's a very active, rehabilitative, skill-based process, as well as a place where they can get their medication and their clinical services. There's also, and you can go to the next slide. Excuse me, thank you. It's also, a whole health approach. We do have an RN on site, and there's a very big focus on health-related goals. So if individuals would like to work on, things like stabilizing diabetes, this program could include that as a goal. You still have to have a serious mental illness to access the program. But this acknowledges that whole health is really what is going to move people toward recovery and symptom stabilization as well. Some of these programs have, tailored services and supports for transition age youth or individuals coming out of psychiatric centers or adult homes. Again, a huge benefit to having not just the meds and therapy, but that rehab component to really help people learn the skills that they may have lost over time due to their mental health condition. All right, and I'm going to go kind of quickly through the next group of services here. So care coordination through the Health Home. Health Home is a DOH program, but it is an integrated care management model, and SMI is a single qualifying condition. So we have a very significant focus specifically on the Health Home Plus population, which is the highest need individuals with serious mental illness. You can go to the next one. And actually, we can skip over this one. We don't need the history. Thank you. And so actually, just this year, OMH designated specialty mental health care management agencies, which are agencies within the large health home network of care managers, who specialize in serving the highest need individuals with serious mental illness and have trained, qualified staff and provide the Health Home Plus level of care, which, if you're familiar with Health Home, the minimum standard is 1 phone call a month. With Health Home Plus, these individuals must be seen 4 times a month, 2 of which must be face-to-face. Again, a little change due to telehealth and COVID, but in general, 2 face-to-face in the community must be provided along with 2 other services. Okay. OMH also offers a large array of housing supports and services. Housing is a very important basic need that we can almost not start working on recovery without that level of stability. We have all different housing models, from congregate treatment in group settings to single room residences and to supportive housing with things like stipends to live most independently in the community. And there's various levels of skills and training supports available attached to those programs to help people maintain their housing stability. So currently we have over 43,000 units for individuals with serious mental illness. Okay. Continuing day treatment is an older program, most of which have phased out with PROS coming on board. But this is a more traditional group day treatment where you would receive your psychotherapy in a group modality, and as well as your medication management. Okay. And partial hospitalization, folks are probably familiar with. This provides treatment for acute symptoms as an alternative to a hospitalization. It may help decrease the length of stay for a hospital, and these are primarily hospital-based, definitely time limited, and could be, individuals can access those for several hours a day. So this focus here is on treatment. You know, we talked about rehab. That is not a part of this modality, and they can be available based on intensity of need. And again, of course, site-based primarily. Okay. Okay, and I'm going to go very quickly through this. Newer expanding initiatives, and I'll kind of just let you know what's important about these. Home and community-based services, or what we will end up calling core services, community-oriented recovery and empowerment services, are rehab services that are mobile-based and limited to those who are HARP members. Okay. We have CCBHC demonstration in this state, as many of you may be aware of. These are not services that are carved into Medicaid managed care yet. So these are things that we're looking at now, very much analyzing outcomes. Untracked New York, also some demonstrations across the state focused on young adults who are entering their first episode of psychosis. A team-based approach that offers clinic services as well as rehab and peer supports. And self-directed care, also a federal demonstration supporting individuals with their behavioral health disorders using their own Medicaid dollars to choose services and supports that work for them. And there are currently 2 sites statewide, and we can go through these. You can skip this one, and I want to say the next couple. Yep, these are kind of just here for your information on those new services. There's a very significant effort right now to establish a coordinated behavioral health crisis response across the population, from children to adults in New York State. And there's a lot of different services. We don't have enough time to talk about them here. Trying to really establish a single point of access for crisis support, so that we can, decrease adverse events that happen when individuals in a mental health crisis may come into contact with the criminal justice system. There are mobile crisis services, crisis residence services, crisis stabilization centers are in development. And this is a very, like I said, broad, far-reaching effort happening right now across our state with different local government units and provider entities. We'll go to the next one. And this is just kind of an important point about crisis, where coordination, I think, with all the services that you just heard about and how we can better ensure that individuals who are in a mental health crisis receive the least restrictive level of support, while also transitioning to follow-up services in the community. So that's part of the work that we are doing now. I think that covers it.
Good morning, all. My name is Trisha Allen. I am an attorney with OASAS Counsel's Office. Thank you, OMH, for going through all of your services. I also appreciated the mention where there was like crossover with the individuals with addiction. So I am actually going to cover the different service levels that OASAS has within its system of care. So OASIS's system of care is kind of split up into, I guess I like to think of it as a continuum. So the first area that we focus on is crisis services. So when we talk about crisis services, what these services are specifically targeted towards stabilizing and managing withdrawal symptoms and any other kind of co-occurring issues that come up, either medical or psychiatric, and getting the person into a point of safety so that they can be linked with the next level of care, be it to a bedded service or to an outpatient service. We focus mostly on stabilizing withdrawal, and then if it's appropriate, induction onto medication assisted treatment. That is something that we are very focused on, especially right now with the opioid use disorder epidemic, because once we get people to a point where they are stable and comfortable and not experiencing severe withdrawal symptoms, then we're kind of able to talk with them and engage them into participating further in subsequent levels of care. These are a lot of times referred to as detox services. So the first level of care, which is the medically supported withdrawal, is an inpatient service. So this is looking at a 24/7 medically supervised level of care. Generally speaking, these are going to be people who are at a higher level of withdrawal symptoms. So these are people who are going to be monitored. We're going to make sure that their vital signs stay stable, work on inducting them onto medication if that's appropriate. And then once that's done, we're going to work on connecting them to the next level of care. One thing to note is these are often referred to as our 816 programs. So Part 816 is the regulation that sets out the standards for how these programs are to be operated. There's also medically supported withdrawal outpatient. So this is appropriate for people who have mild to moderate withdrawal symptoms. So they aren't showing as likely to have severe withdrawal complications. They're able to be monitored through, assessment and monitoring, but they're still able to be outpatient. I know it doesn't entirely make sense because it's within our 816 regulation, but as part of the 816 program, they will do this medically supported withdrawal, but the person does not stay overnight. Generally speaking, the staff will assess these people and identify that they have a relatively stable living environment, so they are able to participate in the outpatient withdrawal successfully. And then medically managed detox. This is again a 24/7 medical observation and management system within a hospital setting. These are for people who have a really, really serious risk of a complication. Usually there's some sort of co-occurring issue. This would be something you would look at for an individual who is going through alcohol detoxification if there were concerns about having severe complications from that. And again, much like the other two crisis service levels, if the person gets to a point of being stable, so they've gone through the withdrawal or they've been inducted onto medication and they're stable, this is when the program is going to evaluate the patient and transition them to the next level of care, be it a bedded service or a hand-to-hand or a direct linkage to an outpatient service And a lot of times when we talk about that, what we're talking about is ensuring that there is an appointment set up so that the person has a way to connect to the next level of care. So the next step down, quote unquote, in the continuum would be inpatient rehabilitation. So these programs are a relatively short stay, but it's still a bedded program, and it's a 24/7 structured program that's going to be a supportive setting to evaluate, treat, and then try and rehabilitate the person who is suffering from substance use disorder. There is care around the clock, 24/7, and it's supervised at all times by a medical professional. A lot of times what you'll see here is that there is a pretty intensive management of symptoms, as well as incorporation of some programming to help the person develop coping skills or stabilization skills. So this is where we're trying to really engage with the individual and teach them how to cope with the symptoms that they're having, and really learn some of those recovery oriented skills that they need to obtain and continue in their recovery. There's, of course, in this setting also going to be conversations about including medication assisted treatment for any cravings that people might have for like an opioid use disorder. Again, very focused on that. The next service level is referred to as an opioid treatment program, or OTP for short. If you're more familiar with the federal language, sometimes they refer to these as narcotic treatment programs, or NTPs. So these programs are also commonly known as methadone programs. So this is a outpatient level of care that will provide methadone to manage opioid use disorder. There is also a focus on incorporating other forms of medication-assisted treatment into our opioid treatment programs, including buprenorphine or buprenorphine combo products. The facilities are also offering counseling and educational services to the people who are coming here. A lot of times what you'll see is people will start at an OTP program and they will be going there every day. And this is, of course, based on federal requirements around when a person has, I guess, reached specific requirements for when they're able to obtain take-home doses, at which point you'll see the person won't be going every day. Maybe it'll be every 3 days, maybe it'll be once a week, and they'll be given take-home doses of methadone or the other medication that they may use for medication-assisted treatment, depending on what their treatment plan is. Generally speaking, in a lot of cases, patients going to an OTP clinic are going to be receiving services over a lifetime. So it's best to look at this as if it's a chronic medical condition when they're getting the OTP services. Next slide, please. So OTP is probably one of our best known services, but we also do have two other versions of outpatient services. One is a, I guess, standard issue outpatient clinic. So this is for individuals who are able to maintain recovery in the community. They will likely get individual and group counseling, and then there's also opportunities for family counseling, and that's a facet of treatment that we've been focusing a lot on in recent years, trying to engage with the family and work on the family as a whole. So that we can address not just the person who has a substance use disorder, but also the family members that have been affected by it. Other services that can be provided would be ancillary withdrawal. So this is for people who are in mild to moderate ongoing withdrawal. Medication-assisted treatment is, again, a heavy focus. And then we do look at a variety of psychosocial services that we're looking to provide to these people to help them build up their recovery skills and maintain recovery. One thing of note, and I think it was mentioned earlier by OMH, is that our outpatient services, because they're in the rehab option, quote unquote, we do have the ability and the authority for our outpatient service providers to provide individuals with services in the community, which means that we have focused a lot on engaging with people where they're at, not just within the four walls of the clinic, but also in the community. You'll see we've done a lot of work with peers. So having individuals engage with people who are in recovery, who are maybe struggling with recovery, to give them the support to help them maintain their recovery. And then we also have outpatient rehab. So this is for individuals who are in the community but need some help with some of their skills. So for example, in recovery, there may be some lack of social skills because in the past the person has frequently been using when they've engaged in social activities. So now that they're in recovery, they may need some support and some help with really understanding how to engage in social activities without having the without using substances. So they'll focus on that. They'll also focus on vocational and educational services and group support. So the outpatient rehab is going to be a more intensive version of outpatient services. And now for the next program type, which is residential services. We have affectionately referred to these as Part 819 services. So there are 3 different levels of 819 residential services. The first up is intensive residential. So this is looking at individuals who need more support in their recovery, including 24 hours of structured living within a residential program. So this is where there's going to be individual and group programming. There's likely to be focus on nutrition, health activities, providing people with interactions with other members of the community who are also working on their recovery so that they can kind of develop the skills to be on their own. Next slide, please. Okay, so I'm sorry, I think I missed one. If you could go back to the last slide, sorry. No, it's just not on there. Okay. Sorry. So there is one level of care that is not mentioned in here, which is our Part 819 community residential. So this is a drop down in intensity of services. So this is someone who needs a supportive environment still. And they'll still be going to outpatient services. They'll be getting educational services and vocational services, but it provides an opportunity for them to have, to develop daily living skills, and it's slightly less restrictive. Now for the Part 819 supportive living. This is considered the least intensive residential setting that we have. So these can be kind of like individual apartments that people will live in. So this is how we support people who are transitioning from a really structured 24/7 environment to one where they are still interacting with program staff, maybe on a weekly basis or a couple of days a week, but they may have their own apartment or have an apartment that they share with other people who are in supportive living programming. And this gives them the ability to kind of develop independence, to get a job, and really kind of engage in that community life with still a little bit of support in the event that they're not 100% ready to rejoin the community on their own. Another form of residential services is our 820 residential services. So this option is a variation of 819, and that we've really focused on, especially with the opioid epidemic, individuals who still need medical and clinical services, and they need to be stabilized. And they are focusing on increasing their coping skills and how to deal with the cravings that they might be experiencing. It also was made to kind of identify when people perhaps don't have a supportive living environment, but it's not as intensive as a hospital level of care. So there are 3 elements to an 820 residential service. The first one is stabilization. So this is focusing on individuals who have mild to moderate withdrawal symptoms and are needing to learn skills to cope with cravings and to kind of manage, obtaining and maintaining recovery. And then we have the 820 residential rehabilitation services. So these are for people who have stabilized. And if you kind of think of it as a linear pathway, someone who's in an 820 residential stabilization could, in theory, move down to an 820 rehabilitation service. So once they've kind of gotten their feet under them and they're kind of stable, you can move them to a residential rehab where we might work on additional skills and best practices for how they can support themselves or others, working towards gaining employment if that's something that's been an issue, kind of understand and learn through counseling and group services how to reintegrate into the community. And then 820 reintegration is similar to our 819 supportive living in that this is a much less structured environment. So people who've been in a stabilization or a rehabilitation setting or another one of the more intensive settings can transition to a residential reintegration and kind of relearn how it feels to live in an apartment or with a roommate, have a job, go out into the community, go to their doctor's appointments, maybe go to their psychiatrist if they have psychiatric needs, and just kind of have support, but limited support as they get more comfortable. Next slide. Okay. So one thing that we did want to make you aware of is in the commercial as well as in the Medicaid space, New York State has requirements for what utilization review programs are permitted. So there is a slight difference, and I'll let Flavio at OMH chime in a couple of minutes about the OMH version. But in 2014, which is not on the slide, the SUD universe, as I will call it, there was a law put in place in the insurance law and the public health law, which said that the Office of Addiction Services and Supports was able to review and kind of approve the utilization review medical necessity criteria that plans were using in the Medicaid and the commercial space when they were looking at the level of care for people seeking SUD treatment. In 2016, that law was modified to its current version, which is that OASAS is able to designate an evidence-based, peer-reviewed clinical review tool that that can be used to determine the level of care that's appropriate for a patient. Now, in the OASAS universe, the designated tool that we focused on was Locator. Locator is a tool that was designed by OASAS with the help of McTack. I think I always say the name wrong, but when we developed this, we looked at the risks that the patient has, the resources that the patient has, and evaluating, can they be successful in the community versus needing to be in a program. This is a very quick tool. I think it takes about 7 minutes to complete it. It's available. You can access it through the Health Commerce system. And this is the standard that we've kind of set for when people are making a decision about level of care. I did include a reference or a link to the utilization review guidance, which you may find helpful. And then I've also included the link to the Locator page for OASAS. So that includes the complete Locator manual, and also, guidance for if you're trying to get access to the healthcare system or health commerce system so that you can use the Locator tool. And it also, I believe, includes contact information in the event that you have more questions. Although I will say, if you do have any questions about Locator generally, there is a mailbox that you can use, which is picm@oasas.ny.gov. And then if I'm not sure if the participants are able to unmute themselves, but I believe Flavio is going to cover the next slide, which has to do with the OMH medical necessity criteria. So
Yeah, Tricia,
Flavio?
this is Alan.
Yes.
Can I just jump in for a minute?
Yes.
Okay. Can I just comment on the stuff Tricia just talked about for a second? Can we go back 3 slides? Okay, go down 1 more slide, sorry. Okay, so the supportive living, oh, I guess it is on the previous slide. Supportive living and the one, can you go back up 1 slide? And the intensive residential, so those 2 programs and the community residences are not covered by Medicaid. So the plans won't have to cover those services. I suppose there's a possibility they could be considered an in lieu of service, a cost-effective alternative, but I don't think there's any medical necessity associated with those 3 residential programs. Inpatient rehab is covered by Medicaid, but the 3 819s listed there are not covered by Medicaid. And then if you can go down 2 more slides. Oh, up 1. The 820 residential reintegration is also not covered by Medicaid. So the plan would cover the stabilization, the plan would cover the rehabilitation, but when the person moves to the reintegration portion of the program, the plan does not cover that. However, we are contemplating working with the federal government to get that service also covered by Medicaid. So I just wanted to make those comments that some of these programs are not Medicaid services.
Thanks, Alan.
And that's it. Yeah.
Okay, folks, can you hear me?
Yes, we can.
Okay, great.
Yeah.
Hi, everyone. My name is Flavio Casoy. I'm a psychiatrist. I work in the office of the OMH Chief Medical Officer. Sorry, there's construction noise behind me. Just really quickly, you know, the Office of Mental Health has been following in the footsteps of our OASAS siblings. In 2019, there was a change to insurance and public health laws that also pertains to medical necessity criteria. The Office of Mental Health doesn't sort of specify a specific set of criteria that payers have to use, but the law does require that insurers and their UR agents have to use evidence-based and peer-reviewed criteria for clinical reviews that take into consideration and are appropriate for the age of the patient, and that have to be approved by the commissioner of the New York State Office of Mental Health, and that happens in consultation with the Departments of Health and the Departments of Financial Services. For your convenience, you can take a look at this link. The OMH has defined guiding principles by which sort of these clinical review criteria and the policies and procedures by which they are applied, you know, are assessed when they're submitted for review. And then we put together a best practices manual. It's a suggested approach on how to best implement policies and procedures to align with the guiding principles. And we strongly recommend that sort of payers implement the approach that's defined and outlined in the best practices manual. There will likely be more on this in coming meetings, coming conversations, but just wanted to introduce the concept here. And I will send it back to our hosts.
So this is Meg from MCTAC. I believe the next few slides cover some questions that were asked previously in the prior webinar. So I'm going to ask our state partners if you'd like to walk through them before we get to our live Q&A.
Hi, this is Laura Salko from OMH. I think we can go ahead and just let them know it's available for their reference there, unless, there is a desire to go through each of them, but we can do the live Q&A first, if that makes sense.
Okay, Laura. So with that, we're going to dive into the live Q&A section of our webinar. So I'm going to ask everyone at this moment, if you weren't with us in the first 2 minutes of our webinar today, I did ask that you chat in all of your questions using the chat box functionality. We're collecting all the questions, and we're going to try and address as many as we can in the remaining time. For questions that we can't address just because of time or because of where we are, or the state might just need to take things back before we can respond, just know that all questions are going to be sent back to the state, so they will have everything. So with that, give me a moment. I'm going to look through the many questions we received, and we will dive in momentarily. Okay, so for our first question, will all HARP members who are eligible with age be enrolled in MAP? And I'm not sure if there's any state partners speaking to this at the moment.
I
you are
can try
muted.
to answer that.
Hi,
Yeah, can you hear me?
Alan, it's Hope. Hi, Alan, it's
Okay,
Hope.
go
Can you hear me?
ahead. Yeah, go ahead.
All right, so hi, it's Hope Goldhaber from DOH. I just want to clarify that MAP, Medicaid Advantage Plus, is a voluntary product. So there is no auto enrollment into MAP right now, other than the default enrollment process that we just started this year. So what we're looking at here is a way to implement BH services into the MAP product to encourage enrollment and continuity of care from the HARP into the MAP. So if somebody is in HARP and becomes eligible for MAP, the MAP becomes an option for them, and there's a pathway to continue their services. Alan, did you want to add anything to that?
Yes. I would say the MAP is only for people who need long-term care. So the people in the HARP that turn 65, most of them are not going to simultaneously suddenly need long-term care at age 65. So most of the people in the HARP would not be going to the MAP. Only the people that need long-term care and voluntarily choose to go to the MAP would go to the MAP. And I think they've set up a way now that duals could stay in the HARP, and Hope knows more about that than I do, but it would be a small minority of people going from the HARP to the MAP.
Thanks, Alan, and thank you, Hope. Hope, don't go very far, because I think I'm seeing some other questions that you might have to jump in on as well. So let's see here. I think this is a question for our OASAS partners. So someone is asking if you can clarify the 819 coverage again.
Yeah, I'm not sure what they're saying specifically, but the intensive residential program, as opposed to inpatient rehabilitation. Inpatient rehabilitation is covered by Medicaid. The intensive residential program and the community residential program and the supportive living program, none of those are covered by Medicaid. And then the third level of what we call the Part 820 program, the reintegration is also not covered by Medicaid, but the other two levels are.
Great, thank you. Okay, let's see here, another question. All right. Will DOH definitively send over the H7 code to MAP plans via 834? And I'm not sure if that question, I'm not sure if Hope, you need more clarity around that question. Let me know. I can ask the person who chatted that in to clarify.
Yeah, and I'll invite my colleagues at OMH to weigh in on this. I think once we confirm the exact coding structure for members eligible for core services in MAP, we will clarify which RRE code that is, and RRE codes do appear on the E34. So right now we're planning to use the H7, but I think we have to still finalize that piece. I'm not sure if Laura has additional info on that.
No, I was gonna see if Emily Hessel, if you had anything to add to that piece, anything closer to it.
Hey, Laura. Hey, Hope. Yes, you both are correct. When we figure out exactly the coding structure, it will go over on the 834. So thank you.
Great. Thank you all. So this is a question related to this, but a little broad. And I think someone's asking, will the new clinics be replacing CORE, or what formerly adult HCBS, as under the new clinic ideas they can provide in community and will have peer services available?
Hi, Meg, this is Nicole. No, the clinic redesign for OMH Article 31 clinics will focus on what can be done under the Article 31 license. Adding peer is one component of that, and the ability for the clinic services to be delivered off-site would be what could happen when we move it to the rehab spa, which is different than the transition from adult behavioral health HCBS to CORE, which those services are rehab services for HARP only under the waiver currently, and they will stay that way. And without going into what that all means and what the services are, it's just important to note that those services are rehab services that are not limited to just the clinic and peer components.
Thanks, Nicole. That's very helpful. Okay, I'm just sorting through these questions. Someone's asking, is there any overlap between Medicare and Medicaid covered behavioral health services?
I can answer that for the OASAS side. For the inpatient services that are covered by Medicaid, Medicare covers the ones that are in hospitals. So if it's inpatient rehab, or if it's a medically managed detox or medically supervised detox inpatient, those Medicare will cover them, and Medicaid would pick up any patient responsibility. For the community-based inpatient programs that OASAS provides, which are pretty much the same programs, except there's no medically managed on the community side, Medicare does not cover them, so the Medicaid side would have to pay for everything. For the outpatient programs for OASAS, so I'm talking about OTP, outpatient clinic in the generic form, and then outpatient rehab, and then there's also an outpatient detox. Those generally, let me back up. So OTP, Medicare covers that. And they don't care who the practitioner is. OTP is covered by Medicare. So all the OTP programs are well aware of this, but the plans may not be. So Medicare is covering the opioid treatment programs, and then Medicaid just pays the patient responsibility. Very rarely would there be any Medicare coverage on the OASAS clinic or the OASAS outpatient rehab. So Medicare is really covering hospital inpatient and OTP, whether that's in the hospital or freestanding.
Thanks, Alan.
Yep.
I'm not sure if there's anyone from OMH who'd like to speak to that same question, or if you'd prefer to take that back.
Hey, Max, this is Shen. Oh, Shen, go ahead.
Go ahead, Emily.
Okay.
Okay, feel free to chime in if I miss anything. I believe for the OMH and for mental health clinic, it's covered by both Medicaid and Medicare benefit. While there are certain procedures that are covered by Medicaid, but not covered by Medicare, so there is the overlap for Article 31 clinic. And also, I believe there is an inpatient benefit. There's inpatient stay for mental health that covered by both Medicaid and Medicare, but there is lifetime cap for Medicare benefits for inpatient, which is 190 days, and Medicaid will pick up any mental health inpatient stay that go above the lifetime cap. And I believe there's also overlap coverage for partial hospitalization. There is Medicaid, there's a separated Medicare billing and Medicaid billing for partial hospitalization. We're still working out the details for the partial due to the complication caused by the different coding taxonomy for partial hospitalization, but that service is covered by both Medicaid and Medicare. Emily, feel free to chime in if I missed anything.
Hey, Shen, I think you got everything. I think the only other piece may be that the clinic component of PROS is also covered by Medicare, but I think that's it.
Thank you, Emily.
Great, thank you. So I just want to acknowledge there are we've gotten a couple questions that are somewhat similar in terms of what services or benefits are covered in terms of what is being carved into MAP. And I think that we're touching upon them in the Q&A, but a lot of the information was covered throughout the webinar. So once you receive the recording, once you receive the slides, you'll have access to this information. And I know that I asked you all to chat in your questions throughout the entirety of the webinar, so I can't quite tell what the timestamp was on this question when it came in, so it might have come in at the beginning before we reviewed a lot of this. So just acknowledging that we are trying to clarify always and to keep your questions coming in, and that we have a couple more to go through. So I'm just going to dive back into the list of questions we have, and I'll be back in a moment to ask the next one.
While you're looking, I'll just mention that in the last webinar that we had a couple weeks ago, there were a couple of tables in there that showed what's currently covered by MAP and what's going to be covered. So those tables were all inclusive. They had everything in there that's going to be covered, and they had the rate codes and that type of information. They didn't talk about Medicare coverage, but they did talk about what the MAP plan will be covering.
Okay, here's a question. Thank you, Alan, and thanks for that. The gentle reminder of the webinar that we had a couple weeks back. So the question is, with the behavioral health carve-in, is one of the goals to enroll members who are in health homes into MAP plans? And just to clarify, the person who asked this question did ask if the person is residing in a health home, and just to clarify that the idea of a health home is not a physical residence. So I'm not sure if that kind of shifts your question slightly, but to the state, with the carve-in, it was one of the goals to enroll members who are within a health home into MAP plans.
I can chime in, and maybe Hope will want to expand on this. So my best understanding of what a health home is it's essentially a case management program, but it's a case management program that's affiliated with all kinds of health care providing entities. So it would be a case management program that's affiliated with OASAS clinics, with OMH clinics. And so that's all integrated together, and everybody's working together to improve your health. But it is not a residential program at all. So the fact that you're in a health home doesn't make you a long-term care person. You need to be a long-term care person to get into a MAP.
Yeah, Ellen, it's Hope, and I think you explained that pretty well. I don't know that we've targeted specifically members with health home services to be enrolled into the MAP. The goal here is really to make the MAP benefit package more comprehensive and really have this product sort of a premier product available to dual eligible members in receipt of long-term services and supports. Some set of those members will be still receiving health home services.
Thanks, Hope, and thank you, Alan, as well. So this is a question about utilization review. So utilization review, evidence-based guidelines used or applied must strictly be those provided by OASAS or OMH, or can additional or other evidence guidelines be followed?
So I think the plan right now, and we're currently identifying a date when we can have a subsequent webinar, because I think that there are some nuances here. And because there are the different standards between OMH and OASAS, we're going to set up an entire webinar to speak about just that. So OMH, I'm not sure if you guys want to add in anything additional. I think the answer is it depends.
This is Claire Rudolph from OMH, and you're absolutely right. We are planning to have another webinar to go more deeply into this question, so stay tuned for dates on that. And it does differ on the OASAS and OMH side. And for OMH, it does depend. Those links that were provided to the guiding principles and best practices manual are there for your reference. And I think that we do not mandate the use of a specific tool the way that OASAS does. We say that you have to follow those guiding principles. So that's kind of the stance for right now. And again, we can get more into that on the next webinar.
Thanks, Claire. All right, so another question. This is around kind of the readiness related documents that were issued. When will the instructions for submitting the readiness related documents be issued? It looks like someone's looking for clarification around that.
I can take that one, and I don't know if anyone else wants to chime in, but I think this is Laura Salvo from OMH. You know, we're continuing to get feedback from the plans and other stakeholders, as well as looking at you know, how the map is currently structured from a programmatic and systems perspective, as well as looking at current utilization data of members accessing these services on the fee-for-service side, which is helping us to inform what the requirements will ultimately be and what we want to establish as potential thresholds, along with, you know, taking into consideration the plan's existing behavioral health experience. So while we're looking at all that information, you know, I think we are trying to target, you know, end of May or early June for those requirements to be related to the plans. And I don't know if there's anything to add to that from my state partners.
Okay, thanks, Laura. All right. Just scanning other questions. Again, some of these, I think Alan noted that information on what is covered can be found in the prior webinar. There are, I guess, some tables in there that kind of frame this a little bit. So for those of you who are asking questions about that, I would refer you back to that at this moment. And if you need access to that information, if you didn't join that webinar, feel free to email MCTAC, and we are happy to kind of share that information with you. We have the recording and the slides available. Just asking folks, if you have more questions, we do have some more time, so feel free to chat them in. I'm going to just scan the list of questions we still have outstanding, and I'll be back in a moment. All right, here's a question that came in related to health homes. Wondering, does the MAP care management requirements supersede health home care management recommendations? If the state's able to speak to that at all on today's webinar.
So this is Hope again, and I just want to clarify that Health Home is already part of MAP. It's included in the MAP model contract, and there is additional guidance on the DOH website regarding agreements that the MAP plans enter into health homes and how to coordinate the care management activities. So as part of the BH Carve, nothing is changing as to health home and MAP requirements.
Thanks for clarifying that, Hope. Okay. Just waiting to see if we get any more additional questions. Okay, so it looks like we did get a request, again, for plans receiving a breakdown by payer for Carve-in services, like what Medicare would pay for, what Medicaid pays for, if they cover both, by each service. I'm going to send that to the state. I'm not sure if that's really a question. I think that's a request, so I just wanted to raise that. And we'll make sure that the state sees that request as we send these questions back. But just reading that aloud, and then we did get this question, when will the updated MAP contracts be released to plans? Wondering if the state has an update on that.
There's a lot of contracting activity happening for MAP, so I'm not sure what specifically the requester is asking about. I would suggest that you send that question to your plan manager, and they'd be able to help guide you.
Thank you, Hope. All right, I'm going to give folks a couple more minutes just to see if there are any additional questions that can come in. And I'm just going to also, while we're waiting to see if there's any other questions, just ask any of the state partners on the line if there's anything else you wanted to emphasize or clarify, seeing as we have a little bit of time, as I kind of sort through and make sure we've covered all the questions that we can at the moment. Okay, we got a question about procedure codes, and folks are wondering when the procedure codes will be provided to MAP plans across the Carve-in services.
All right, I'll start with an answer on that one. So we've been asked about the procedure codes a couple times. The crux of reimbursement for OMH and OASAS services is rate codes. And the plans are required to pay based on the rate code, not the procedure code. And they're required to report the rate code on their encounters. So we provide, in the event that we do mandate the Medicaid rates, we will provide the plans with tables that show the rate code, the provider ID, and the locator code, or the rate code, the MPI, and the ZIP+4. And then in where they're using APGs, which are the only ones that would be government, no, OMH has government rates mandates outside of APGs, but for OASAS, it would all be the outpatient stuff that would be government rate mandates. The APGs, you need to see the rate code, but then you also have to look at the procedure codes. So I think we're going to need a more specific question. I mean, what procedure codes do you want to see? Because we're doing everything off of rate codes.
Thanks, Alan. So for the person that chatted that question in, if you want to chat a clarifying question in, I'll be happy to ask that.
Yeah, and OMH can speak to their services, but on the OMH side, very, very, very dependent on rate codes.
Hi, Ellen. This is Shen with OMH. I just want to chime in for OMH, and it's consistent. It's the same thing from the OMH side. The traditional Medicaid fee-for-service billings, relies on rate code, but we also understand that some of the plan systems, rely heavily on the procedure code. So for the OMH, services like inpatient, clinic, like ACT, PROS, besides rate code, we also provide a crosswalk from the rate code to the procedure code. And since we have the mandated rate or government rate, whatever you want to call it, we made sure that for every single rate code, because it corresponds to a specific rate, it has a unique combination of procedure code and modifier to walk it through back to the rate code. So I believe we plan to provide you guys with the rate code and also the procedure code and modifier in the near future. But before we do so, we encourage MCOs to review the billing guidance, including rate code and procedure code. We previously provided in the last webinar. I don't know, Matt, please feel free to chime in if we have ever shared our previous slides. I believe we did include a link to the billing guidance, which has all the rate code, procedure code, and modifiers for OMH licensed services, and also probably I think the OASAS services are also included there.
Thank you, Shen.
Yeah. So
Go ahead,
can I
Alan.
just chime in some more? So
Yep.
yes, when I worked for Office of Mental Health, we created a crosswalk of all of their PROS and ACT and partial hospitalization, continuing day treatment. We crosswalked that all to procedure codes. And in order for that to happen, since the procedure codes don't perfectly define those services, there's a lot of modifier codes added on there. That logic doesn't apply to OASAS because we pay for everything on the outpatient side through APGs. And in APGs, pretty much any procedure code could be on the claim. There could be a physical health procedure code on the claim in APGs. So for OASAS, we conceivably pay for hundreds, dozens at least, but potentially hundreds of procedure codes under APGs, whereas OMH is going to say procedure code 9XXXX and modifier U6 and modifier M1 is partial hospitalization or 1 to 40 hours. So it'll be some oddball thing that is impossible to define in procedure codes. But for OASAS, the procedure codes all pay through the APG group or pricer. So we're paying for all the procedure codes that pay in APGs on the OASAS side. There's some policy restrictions around them, but pretty much we're paying for any outpatient procedure code.
Thank you, Alan. Okay, I'm just scanning any other questions that have come in. I know we have a little less than 10 minutes, so I want to encourage anyone, if there are any additional questions, to chat them in. As our state partners have indicated, we are working on scheduling and setting up a subsequent follow-up webinar, either happening later this month or early next. And all of the questions we're collecting today, our state partners are going to receive. So if there's any other further clarification they want to provide, our state partners will absolutely have the questions you've asked to provide that clarification. Okay, I'm going to give folks another minute or so. I'm not getting any more in the moment questions. So with that, I'll give folks another minute, but also I'm just going to ask our state partners, anything else you want to emphasize or cover before we conclude our webinar today?
This is Laura Salvo from OMH. I don't have anything else.
Thanks, Laura. Anyone from OASAS or HOPE, anything you want to cover? Anything else from DOH?
Hi, this is Hope. Thanks. Nothing at this time.
Okay. Sounds good.
This is Trisha from OASAS. Nothing for us either. Thank you.
All right. Well, on that note, I'm going to thank everyone again for joining us today. As I shared earlier in the webinar, this is being recorded, and the slides in the recording are going to be made available to everyone. So look for that in your inboxes in the coming days. And as noted by our state partners, we are looking to schedule a follow-up webinar. So we'll also be looking for an announcement around that. And I want to thank all of our state partners who joined us today and shared this really important, critical information, as well as all of you who have joined us on the line. We thank you for your questions and your participation. And with that, I'm going to say have a wonderful day. And we will be back online with you soon for our follow-up webinar as soon as it's scheduled. Thanks so much.